Genetic Alliance webinar addressing gaps in genetic services, regional and national models in the United States. My name is James O'Leary. I'm the Chief Innovation Officer at Genetic Alliance. This webinar is co-sponsored by the Genetic Alliance as part of the National Genetics Education and Consumer Network and the larger project that is part of the National Coordinating Center for the Regional Genetic Services Collaboratives. And that project is led by the American College of Medical Genetics. We're lucky today to have Alicia Keene joining us from the American College of Medical Genetics and the NCC to present the report developed by the working group that is the subject of this call. Unfortunately, Celia Kay is unable to join us at the last minute, but Alicia is pinch hitting for her, and she is totally up to date on the workings of that group and can give us a full report. So a couple reminders as part of the webinar. You are muted, but you can ask questions and put comments using the panel on the right-hand side of your screen. And I do encourage you to do that throughout the webinar. We will be getting to those comments and questions at the end, but we will record them throughout. And it actually helps us out to have them listed early, and then we can group them to like questions together. Also, as a reminder, this webinar is recorded, and the recording will be posted on Genetic Alliance's website. We also have a lot of other great webinars up there, so check them out. So to start us off for today's webinar, just to give you a brief overview, we're going to give information, context around genetic services in the United States, including some data collection that we've done here at Genetic Alliance, and some data collection we're in the process of completing. Then Alicia is going to give an overview of the methodology and process and some of the major models that were looked at by the working group, as well as giving you information on how to download the recommendation brief that is the subject of today's call. The whole point, though, of this webinar is to get you comfortable so that if you would like to, you can make comments on that recommendation brief, which will be delivered to HRSA, to the Health Resources and Services Administration, specifically the Genetic Services Branch under the Maternal and Child Health Bureau. A little bit of background on this project. This project is part of the Regional Genetic Service Collaboratives. If you're not familiar with those, there are 7 regional genetic service collaboratives which are funded by the Genetic Services Branch. The original funding for those collaboratives came in 2004, but the most recent funding period is June 2012 through May 2017. And they're housed at different university and public health departments throughout the United States, but they work with health professionals and consumers around the country. So if you're not involved with them, they're great organizations to get involved with, and they work on a whole host of issues and topics in genetics and newborn screening. The coordinating center for those groups, as I mentioned, is led by the American College of Medical Genetics, and also part of that is the National Genetics Education and Consumer Network, which is led by Genetic Alliance. And that grant period is June 2015 through May 2017. The mission of these groups is to strengthen and support the genetics and newborn screening capacity of states, but also to improve the availability, accessibility, and quality of genetic services and resources. So as part of this project, essentially what we were trying to do is identify needs and then ways to address those needs through regional service and support centers. And that was requested by HRSA as they looked towards their planning for the future and how to address some significant gaps. We knew before this process that some of these gaps exist, as do all of you. But there's really very little data available on a national or even a regional basis. Certainly there have been some surveys on specific needs for genetic services and for individuals and families with genetic conditions, But many of the surveys or many of the data points tend to be condition specific, so not covering the thousands of genetic conditions that are out there. And there's a lot of missing data on things like uptake or availability of infrastructure within the states. So we've been really trying to address that as part of this project. In addition, we know that there are not enough genetics providers, that there's an increasing demand for services as genetics enters the clinic, not only for caring for families with genetic conditions, but also for supporting individuals who are receiving genetic testing, whole genome sequencing, and those types of services. We also know that it's a somewhat aging workforce, specifically the geneticists that are available, and that there isn't even coverage across the different states. We also know that coverage is inconsistent, and that cost, especially when you're talking about a serious chronic condition, can be a very, very significant burden for families. And we also finally know that many genetic conditions are complex, care coordination is complex, transition to adulthood is complex. I mean, even our awareness of the prevalence of these conditions is quickly changing, and therefore our awareness of how differential the phenotype can be, the symptoms for these conditions. So with that said, I'm going to turn things over to Sharon Alexander from Genetic Alliance, who will give a little bit more information on some of the national data collection that we did, and I think many people on this phone call helped us with, helped disseminate our survey. Sharon?
Great, thanks so much, James. So as James mentioned, we've really been kind of building up momentum for a while for this project, hearing from families along the way. We've heard many anecdotal stories about issues accessing care and what would improve the healthcare experience. But one goal of this project was to gather some quantitative data and be able to point to some common themes across genetic conditions and whether access issues differ geographically. We also wanted to collect data that would be actionable for this project. And that means that we could use this data to support and show the need for programs and or services of the future regional genetic services centers. And we began back in January of 2015 with the National Coordinating Center conducting listening sessions with different stakeholders across the nation and to talk about what they anticipate will be needed to improve access if you think forward to how healthcare and the healthcare system might differ 5 to 10 years from now. In July, Genetic Alliance as NGCN hosted a webinar. We wanted to gather some feedback and ask different communities about factors impacting access to care. And from those discussions and discussions along the way with our consumer advisory group, we developed a national survey to try and get at if and why individuals and families are facing challenges, and then how. So what potential solutions or roles future centers could play in addressing these issues. Our consumer survey was fielded at the same time as ACMG fielded a provider-focused survey, and Alicia may mention that. But today I'll focus on some of our findings from the consumer survey and then pass it over to Alicia. So I should start by saying that all of these efforts build upon the work that Genetic Alliance in a previous grant cycle as NGCN began back in 2013 with an initial survey that we conducted on access to care. The survey we developed and fielded in 2013 was really the first of its kind to ask questions across genetic conditions and across the lifespan. And we used many of the validated questions from a national survey that's fielded every couple of years, specifically to children with special healthcare needs, which of course is not specific to genetic conditions and is only limited to children. So our goal was to see if and how care for individuals with genetic conditions, particularly, might differ from the broader population. And so here's a few of our takeaways from that 2013 survey. You can see that first, the majority of individuals receive care from a system of providers, yet we found that only 1 in 5 people had someone to help coordinate their care across these providers, and nearly a third were very dissatisfied or dissatisfied with the communication among these providers. We also heard that 42% of individuals never or rarely received social or emotional support from their healthcare provider and or a support group, and only 33%, so a third of individuals, most of whom through the survey we know were connected to support groups, were referred to support by their healthcare provider. So seeing this data back in 2013, we hope to really get at the root of some of these issues and begin to think about ways these supports or services could be improved. Looking at some of the overarching needs we heard loudly from the 2015 National Needs Assessment we conducted as part of this project, the #1 issue experienced around genetic testing was a lack of healthcare providers with knowledge of the genetic condition. Over half of the respondents felt it was very hard to know where to find providers with knowledge about the condition. And again, the biggest barrier reported was the lack of providers with expertise in a particular condition. So thinking about where individuals look for information and support, you can see the top place that was reported for information was an internet search, which is a little scary considering the world of information out there, which can sometimes be very overwhelming and tough to discern. Places individuals found support for their condition, supporter advocacy organizations, fellow parents, and others. And again, we found that a large percentage of people said they did not receive any emotional support around their diagnosis. And James will talk a little bit about why we think this matters so very much and what else we're doing through our other projects at Genetic Alliance. We asked about how difficult it was to find information on the following topics. And here you can see the percentages of people that felt finding information was very hard or somewhat hard. In accessing services and supplies, you can see nearly a third of respondents said it was very hard to obtain specialist visits in the past 12 months, social and emotional support, and then followed by therapy. We also asked a series of questions about patient navigation and services that would be most helpful. And here you can see what the top responses were: help understanding the condition and where to find relevant resources and supports, and then recommendations for local genetics and medical providers, and from whom individuals would be most comfortable receiving information about their condition. #1 listed was a fellow parent or individuals with a condition, so someone who may have a similar experience, and a care coordinator within a specialist office. We also asked a number of questions about telemedicine, especially as telegenetics is something several of the current regional collaboratives work on. Here you can see that the large percentage of individuals have not been offered by their genetic specialists to be seen via telemedicine, though a large percentage, you can see the blue bars, said they would be willing to receive genetic services via telemedicine at a nearby clinic and or in their home. So a potential for something that the future centers could offer. And lastly, and this will tie up today's summary of some of our findings, though we are in the process of summarizing and getting this data published out for the field. Again, many of the issues experienced around adult care are similar to the overall needs expressed in finding providers and social and emotional health and wellness and cost, which very likely could be due to changes in insurance as young adults switch to their own coverage. And since we talk a lot about transition in this world and also lack of care providers, we were surprised to hear that over a third of young adults who needed help identifying adult specialists did not receive that help from their primary care provider. So again, potentially an area for improvement and better access to care.
Great. So this is some preliminary data. It was only 2 surveys, and obviously we're limited by the total number of questions we can ask, but we felt like it was an important start. Genetic Alliance, though, is really focused on expanding knowledge in this area. We are currently doing a landscape analysis and doing site interviews around patient navigation programs and models that exist, and we'll be releasing a monograph on that topic this spring. We are refreshing and building out our resourcediseaseinfosearch.org, which will also have a major release this spring. It's a search aggregator site for information on over 10,000 diseases. We'll also be building out a services piece of that. We also looking to study the impact of referral to support and are submitting grant applications on that topic. What are the actual clinical and kind of secondary outcomes from referral to support, as well as looking at things like accessible genetics education, certainly, and the capacity to build on public health genomics and make those services available to individuals and families. So this data collection is part of a much larger effort and an area that we hope to build out and paint the picture of services over time in the United States. So with that context, I want to turn things over to Alicia Keene, who will give us more information on the report and some related information on genetic services, specifically from the provider perspective. Thanks for joining us, Alicia.
Thanks for having me, James, and thank you to you and Sharon for setting up things and providing a good context and backdrop against which we, through NCC and in partnership with you all as NGECN, were considering what future regional genetic services might look like. So this project began as part of our continuation funding from HRSA, and as of June 1 of last year, we were asked to develop, in conjunction with the data and big picture that James and Sharon have provided, a sense of what could the future of regional genetic services look like. And in order to do that, we thought, well, that could be a pretty large task. So let's think about how we might do this in a very logical and stepwise fashion. And not only were we told to begin this in June, we also were informed that we needed to have this task completed by March of this year, so next month, and to be able to provide a recommendation brief of models for future genetic services centers. And that's really what I'm going to spend the lion's share of today talking with you about and sharing with you, because we would like the month of February to be a comment and feedback period to us of the draft that we have today, and I'll get into some of the details about that. And in order to achieve this whole recommendations brief and to see this project through, we convened both a regional support service model work group and an advisory committee, who are both chaired by Dr. Celia Kay. I'm going to see if I can advance.
Alicia,
You can drive me. Perfect.
Yeah.
Okay, so the charge to the work group and the advisory committee's charge, I'll say, was very similar. But specifically, the work group was really, they met twice per month, sometimes 3 times per month. And they were really charged to do the lion's share of the work that I'll get into. And the advisory committee met about once per month and was really there to sort of offer some leadership and guidance to the actual work group itself. And so the charge of the work group was to review existing regional models across a variety of systems, healthcare delivery, public health, and other countries. And based upon the review and other information being gathered, simultaneously through the needs assessment, of which Sharon showed you a bit of the consumer level data, we also conducted a needs assessment of healthcare providers. And combining that along with review of existing systems, regional in nature, the work group was to develop a recommendation for a model or models of regional centers, particularly for those populations that have limited access to genetic services due to geographic, economic, cultural, and other barriers. Next slide. So the purpose of the work group was really to bring together diverse consumers, genetic stakeholders, and other healthcare providers in public health to develop these recommendations, and ultimately the recommendations brief that's now available for comment. Next slide, please. The process the work group and advisory committee used was to consider regional genetic models, the list of which were derived primarily through the listening sessions that Sharon mentioned that we held and touched more than 250 participants that represented consumers, healthcare professionals, both those genetic and non-genetic, and public health. And then NCC has a host of subject matter work groups, a care coordination work group, an evaluation work group, and those work groups also contributed suggestions. The work group, speaking now of the regional support service model work group, considered those regional models, developed recommendations on the basis of those regional models and the needs assessments that were completed in the fall. And I've already mentioned our task. So February 2016 is when we're looking for comment on this brief, and then March is when this brief is due to HRSA. Turning now to the actual recommendations brief itself and what it contains. The brief identifies key needs and priorities that were revealed through those national needs assessment and then refined through an iterative rating process that was utilized by the RC project managers and project directors, the Regional Support Service Model Work Group, its advisory committee, and then also a cohort of genetic counseling students. Much work was done in identifying the priorities from the needs assessment, and the 6 main priorities that were identified and pursued were formal relationships, education and training involving both non-genetics professionals and the public, promoting family engagement, practice support, promoting efficient practice, and data collection. And you can see these further explained in further detail in the brief itself. Next slide. It was important to the work group and the advisory committee that these priorities be considered in conjunction with the maternal and child health pyramid, given that this larger activity and the basis of where the regional support services will come from is public health derived and focused on access. We wanted to make sure that as we considered these priorities, we looked at them across the MCH pyramid. And so where you see indicated in green are where we believe that the priorities would touch upon either infrastructure building, population-based, enabling, or direct healthcare services. Next slide, please. In addition to the 8 identified models you see here, we considered more than 20 models of regional centers, both the hemophilia networks, the United Kingdom Regional Genetic Services Network, CF, cystic fibrosis network, and a whole host of others, again, which are available, the review of in the recommendations brief. To get ideas really for future genetic resources centers of the future. It was important to us as we came up with this list of models that we didn't just operate in a vacuum and sort of pull things from the sky, that we really looked towards those regional centers and models that had been successful. And so using those as the backdrop, we ultimately ended up with these 8: a regional genetic service resource network, regional clinical support centers, regional genetics education and technical assistance centers, regional patient engagement centers, a public health-based model, a quality improvement-based model, a regional clinical support network, and then genetic service data centers. And what I'll say about this last model in particular is that it really is taking a step back from really, in the short term, getting any specific services. It's really about building the data infrastructure to support ultimate projects that would be a much longer term activity. So for the next few slides, what you'll see is what's contained in the report, and that is, next slide please. You'll see in the brief, I should say, a model by model review, a description, both describing the activity and then sort of what we think might be the infrastructure for that activity. Then pros and cons of each model, priorities, again, thinking back about those 6 identified priorities I referenced a few slides ago, and then both timeline to develop and then timeline to implement and then have any sort of initial data collection and or reporting. Then finally, you have outcomes and what we believe would be promotion of how each model would be a promoter of efficient use of resources. I won't go through each of these in detail. We can go to the next one, which is Model 2, Regional Clinical Support Centers. You'll see the description here. Again, Model 3, Regional Genetics Education and Technical Assistance Centers. Model 4, Regional Genetic Patient Engagement Centers. And there are differences between each model, so I do encourage you to really look at these in detail. The brief is only 20 pages. There are extensive appendices, but the brief itself, we really aim to keep it concise and clear. And so looking at between the distinctions and providing us feedback, we'd really appreciate. Model 5 is the public health model. Model 6, again, is the quality improvement model. Model 7 is the Regional Clinical Support Network, really focused on clinical services. Model 8, as I've already mentioned, is the real data center. So think of this model in particular as very data driven, and really any funds that would go towards this activity would really be designated for simple data infrastructure development and primary baseline collection. So turning now to recommendations. In consideration of the listening sessions, of the national needs assessments, of the over 20 regional model reviews, and then in developing both the priority list and then these 8 models, the work group ultimately, and was supported by the advisory committee in recommending the adoption of a hybrid of models 1, 2, and 3, with a primary focus on promoting efficient practice within genetics centers. That would include technical assistance for genetics, technical assistance for authorization of genetic testing and other genetic services, technical assistance for genetic counselor licensure and billing, as well as identifying through other interactions with genetics providers. And also contemplated within this is that care coordination between genetics providers and non-genetics providers. And by genetics providers, we really do mean not just geneticists. We mean genetic counselors, we mean dietitians, we mean all of those specialty providers that are sort of housed under the umbrella of genetics. We know that that also can include physician assistants, that can include nurse practitioners, and what has come through over and over again is making sure that as we move from this specialized genetic knowledge to non-genetics providers, and again we mean all healthcare providers, that there needs to be education and provision of point of care clinical decision support and useful information that can help those primary care providers and frankly other specialty providers really have a stronger sense and ability to care for individuals with genetic conditions and really meet their needs. The other part of this recommendation is that there should be really a development of other tools to enhance the level of care that can be delivered. And again, beyond the walls of the genetics center itself. Recommendation 2, oops, sorry, I skipped. Recommendation 2 is really just a reemphasis that indeed a regionalized structure, whether it looks similar to the regionalized structure that exists now or not, but that regionalized structure has really been replicated and utilized across many other healthcare systems. It's been utilized in public health. It's well utilized and is a strong infrastructure basis for future programs. And then that there is a strong role for central coordination to help with national level data collection, to help with linking at the national level. So those were, again, recommendations 1, 2, and 3. And then turning to the final recommendation, recommendation 4 is that a recognition and a recommendation that really the function of genetic support centers is between and within healthcare delivery systems, and that the role of public health really can't be underemphasized, especially as we look to the future and we see where we believe genetics information and the ability to learn so much in such a short amount of time. We think that public health has a very strong role here. Now, recommendations 5, 6, and 7 were recommendations that were based in gaps. So what I mean by that is that we really identified these as gaps, and that we thought that elements of these were really beyond the purview and frankly the funding level of what the future genetics regionalized systems might look like. And so really you have to think of these 3 as sort of gaps. So our recommendation around the need for provision of non-genetics provider education is that this is really the role for professional organizations such as the American Academy of Pediatrics, the American Academy of Family Physicians, and the American College of Obstetrics and Gynecologists, and others, that they have their own professional membership organization linkage, and that work could be done betwixt professional membership organizations at the national level to really help improve that, but that might be something that's really beyond the scope of our work. Leaving aside, of course, what I referenced before, which was the clinical decision support and some of the just-in-time information that we still think could be a role for a regional system. Looking at recommendation 6, data collection clearly overlaps with many of the recommendations we've made, but it also overlaps with some of the current functions within HRSA now. And we are really recommending that HRSA look within HRSA and some of the other funded entities and offices within HRSA to really enhance large-scale data collection for genetics so that we can have some population-level data so that we can look at how our work interplays into the broader funding environment within HRSA. And then recommendation 7 was taking another look at workforce. Throughout this, and we identified that there is a huge gap and need at the national level for an increase in the genetics workforce. And again, not just referring to PhD or MD geneticists here. We really mean all level of genetics providers, genetic counselors, and metabolic dietitians in particular are definitely at a shortage. And some of the, we have some ideas about some short-term solutions in education, but in terms of really buttressing those professional areas, that is something that we can't do in the short term through a regionalized network. But that there are things that can be done nationally and federally to really help support and offer some of those incentives for people to pursue these career paths that maybe they're not pursuing now. But that, again, this is really outside the purview of what a regional system could do in the future, absent a huge influx of funding that we don't expect. Next slide, please. So now that I've provided with you the backdrop of the process and then covered the recommendations briefly, it's your turn to consider the brief in more detail and with more reflection. And we're really asking you to provide your comments in written form, and we would like to emphasize that we will be removing any identifying information in terms of name, address, etc. And we're asking you to submit your comments to this email address below no later than February 26th. And by comments, we mean they can be questions, they can be a quick bullet note observation. Overall, it can be specific, page 2, paragraph 3. We really, any reaction you have, we would really appreciate hearing from you. This is really our chance and your chance to collect feedback about what will go forth to HRSA in March as a final recommendation. So the brief is available now on the NCC website, and I believe NGECN has a link over to it. I believe there's a link over from Genetic Alliance's page. There is a link over from the ACMG homepage. We really are trying to, we were sending this out via social media. We are asking you to share this broadly and extensively and often so that we can get your input, because while it is up to HRSA's ultimate discretion to pick the direction that they choose to take genetic services in the future, this is really, again, our chance to really offer some thoughts and suggestions to them. Next slide. So our final deliverable, as we've mentioned a few times, is that in March, we are to provide to HRSA a recommendations brief that discusses potential regional support service models, sharing pros and cons and costs. That last piece, where possible, that has been a difficult piece to get at, because while we have a sense of total cost for certain different programs, a real parsing out of costs, for instance, how much would it cost to develop a data collection infrastructure, was just not available to us. But we are doing some additional exploration right now, and you'll see in the draft that we have a placeholder, because we are hoping to be able to spend the time over this month to look into what we think might be cost elements and get some more information. I do want to mention again that this brief is really meant to be just that, a recommendations brief. Final programmatic decisions and changes will be the sole decision and discretion of the Genetic Services Branch of the Maternal and Child Health Bureau at the Health Resources and Services Administration. So this is not necessarily what will end up being reality. This has been our opportunity to take a look at the universe through national needs assessments, through listening sessions, and really offer up to HRSA what we think might be some models for the future. Next slide. So I'll hand it back over to James and Sharon.
Great, and I do want to also say that this work is certainly not just going to end with this recommendation to HRSA. Both the American College of Medical Genetics and Genetic Alliance and the regional collaboratives obviously have a broader interest in these needs and how to address them. Some of these are things that can be addressed short term, and some of these are very long-term issues. So make sure that your voice is heard on this, not just for the part that's going in the recommendations brief to HRSA, but also the very important discussion that needs to happen in our community about what data needs to continue to be collected and what programs would be useful, where we can get funding to complete those programs, and how they can be sustainable. So we welcome you now. If you have any questions or comments, we'd love to hear them, and then certainly we welcome you to look through the recommendations brief and submit comments in the next few weeks.
Great, and if you have any questions right now, feel free to type them into the chat box. Otherwise, of course, you'll have an opportunity immediately after the webinar to share your questions, and then also on the report site. So we're not seeing any questions come in, though we did get some questions throughout the webinar. So, and we answered those, as they came in to individuals. And so if you have any questions about any of the content we covered, let's see. We did just get a question. And the question is, how does HRSA support community involvement in the clinic?
So we don't have a representative from HRSA speaking on this call, but I can certainly answer that question somewhat. HRSA as an agency has a huge commitment. There is, in fact, a whole branch of HRSA that focuses on community health centers and providers, supporting patients and providers. The Genetic Services Branch as well has done work. They had a previous project that focused on looking at integration of genetics within the clinic, and that was led by the American Academy of Pediatrics, and it was called the Genetics in Primary Care Institute, so check that out. Also, Genetic Alliance has previously worked with HRSA to focus on community health centers and family health history, integrating family health history in its collection in a sustainable way within community health centers, linking them to genetics programs, and also increasing education in that context. Alicia, do you want to reference any specific programs that you think are particularly interesting?
You covered the ones that came to my mind quickly.
Okay, great. And certainly the regional collaboratives, and this is why I would absolutely encourage you to participate, have done pilot programs and support programs in these areas across the country. Specifically, some very interesting training of patient navigators that can be embedded within the clinic, all sorts of education, genetics education as well. And those programs are all listed and highlighted either through the NCC or through the regional collaborative websites themselves. And it looks like we have a lot more questions coming in.
Great. Yes, thank you. And please continue sending those in. So the first question, and I think this is for you, Alicia, can you elaborate on the data, I guess, that came up around training non-genetics providers about genetics and the need for that?
And why you feel it is the role of others to take up that mantle.
So our national survey, one of the areas that were indicated as a need and a gap on the provider side was education for non-genetics providers. And we believe that the role, so there have been a lot of funded activities both historically between NCC and, for instance, in partnership with the American Academy of Pediatrics. Work has been done between the March of Dimes and some of the primary care membership organizations in the past. And in particular, the first iteration of the Genetics and Primary Care Institute that James just referenced, we had a number of folks involved in this project who had been a part of that project also. And they thought it was very important and that much success had been achieved in providing very specific, tailored, for instance, just-in-time information to primary care providers, and that there had been successful uptake in that area. But in terms of broader reach and really reaching all of the membership, and really in terms of an in-depth permeation or reach into those professional entities, both through the membership organizations and then even just trying to reach them through the community. A number of regional collaboratives have done pilot projects that have been more successful on the local level than on the national level. And the thought of the group was that this is for sure important. There's no disagreement about that. The question that the group really sort of spent their time dissecting was thinking about what would be the role of a regional support service group versus something else that could happen or that should be happening, or a national level effort that could be happening around continuing medical education, continuing education units, et cetera. And some of those activities have been successful, some have not, and that it really would be a better discussion to happen outside this regional support service model, given so many of the other needs and the desire to really push forward access to services and really push forward how to make that happen. That with the limited funds that we believe will be available to this project, there just had to be this sort of parsing out of where we thought push could happen. And that's again why it made it into the recommendations, is that we didn't want to say that we didn't think it was important. We just weren't convinced that this was the best mechanism to do it.
And I do want to clarify too that this is not the National Coordinating Center as an entity's recommendation brief. This is rather a working group that was put together of kind of innovators in the field and representatives from the regional collaboratives that made these recommendations.
Correct. Thank you for making that clarification.
But please, if you have thoughts or recommendations, comments on that priority setting, those are exactly the types of things we'd love to have people submit formally, so that we can include those with our brief. Next question.
Sure, and we did get a comment referring to that, I think, a little bit, is that the GARD, the Genetic and Rare Disease Program at the NIH, for example, is one other resource that can be helpful in finding answers. So there's resources out there for finding information about genetic conditions as well.
And you know, that's a good reminder of the fact that that was a recurrent discussion also within the group, is that better than developing new resources, really helping how do we increase uptake of the existing resources, and that again could fall within that technical assistance purview of a regional center, and that we don't, you know, that we're very mindful about not duplicating resources. And again, these are great comments, as James just said, to put into that email address and shoot to us. Again, even if it's just that one sentence, that is very helpful to us.
Great. The next question is regarding social and emotional support and the connection with it with other parents and also knowledgeable care coordinators, how are they being seen, how is this covered within the hybrid model recommendation?
So we again think of that as part of the technical assistance function of what a regional support service model could be and could contain. And you'll see in the recommendations, we do kind of leave it open. We have not been specific in saying to HRSA that it should be one form of technical assistance over another. And so if you think strongly that that should be a piece of the recommendation, please provide that comment to us in written form.
Great. There's a couple questions kind of about the structure of the regional collaboratives and the National Coordinating Center, and so, which we're really excited to see. The first question is, how do you volunteer for a regional group? That's a great question, and if you go to the National Coordinating Center's website, and we probably have it on the slide, nccrcg.org. You can see a picture of the regions and find the region to which you belong, depending on where you live. And then you can find all the contact information for those regions for the staff people, and they would be very happy to have you involved in that. And there's also opportunities for consumers to get involved across all of the work groups in the regions, and many of them have, family advocacy work groups as well. So do check that out. And then the next question is regarding clinicians participating with the regional collaborative, and how, the question specifically is, how do they encourage clinicians from different collaboratives to talk beyond the meetings in person? But maybe, Alicia, you could talk a little bit about some of the work groups.
Yep, that's perfect. That was a great setup. So we try, I mentioned them briefly and I did not go into detail about them, but NCC, in addition to this work, has a whole host of subject matter work groups that meet on a monthly basis and occasionally meet in person. And the membership of those work groups is comprised of regional, similar regional work group chairs who are often clinicians along with national experts. So we encourage on a monthly basis a sharing of what's going on, both funded within a region and both sort of within that clinician's world. And that is one way that we try to really share across and really engage clinicians beyond just a specific subject matter task. And it's a way we really try to have bidirectional information flow of what's happening locally up, and then what's happening nationally back down. So for instance, our care coordination work group is comprised of clinicians and consumers from the regions, and then also the American Academy of Pediatrics participates, and they share some of their nationally funded activities too. So that, again, that linkage and that sharing and growth of information and resources that are being developed exists. And that similar model is what we utilize both in our evaluation work group, in our clinical decision support tool work group, and our healthcare access and financing work group all follow that same model. So that is one way in a work group specific fashion that we try to engage clinicians. And then we reach out through the professional membership organizations, for instance, AAP and AAFP, as examples of how we periodically share information. We try to link them into both at the regional level, so some of the AAP state chapters, the regions have reach out into them and do sort of either continuing education course offerings or different mechanisms that way, so that we can again engage providers.
Great, thanks, Alicia. Next question about this presentation really is, will this set of recommendations and the overall report inform how the NCC and regional collaboratives work and interact and are funded after May 2017? Maybe you could clarify a little bit.
So it may or it ultimately may not. It may be that pieces of this recommendation filter into other HRSA-funded projects within the genetic services branch. We don't have a promise or an expectation that what we've put forth here will be what is ultimately adopted. HRSA may choose to alter the landscape of how the regional collaboratives are comprised. Right now, their regional boundaries have been established based upon across the country sort of relative birth rates. So you'll see that the New England Genetics Collaborative is much smaller than, for instance, the Western States Collaborative, and that is because the boundaries were established based on that relative annual birth rate, and then also sort of related, similar already existing relationships. It may be that HRSA decides not to have 7. It may be that they have 12. It may be that they have 4. Those details we are not privy to, and that is not what we were asked to consider here. We were simply asked to think about what those regional centers might do given the changing landscape of both needs from the consumer side and then sort of the changing landscape within broader healthcare delivery. So we have no promises or guarantees that any of this will be utilized, but we do know that they are taking what we are offering to them very seriously, and we'll consider it. It's just a question of, I don't know that we can expect. In fact, I wouldn't want to be on the hook for saying that we can expect to see recommendation 1 be exactly what is translated. There are many other things at stake within HRSA, and there are many other avenues that they may choose to sort of direct. So they may think, it may be that one element of this seems important, but it may go to something else that's already funded, or HRSA may determine that there's a different direction that could take.
Great. And certainly they did request feedback, so it is very important to comment on this because it is one of the major avenues I know that they're soliciting feedback through. That being said, we have always a whole range of people on these webinars, people that are policy wonks to other individuals who are just getting into advocacy to providers. So a little context on these types of documents too. There are lots of groups that put out recommendations on different topics, the Institutes of Medicine, working groups, advisory committees, and sometimes I feel unsure at what's going to happen with a white paper. You put out the white paper, it's kind of in open space, but then what I find typically is that what happens is it's out there, and either for a piece of legislation or a new funding opportunity or some internal working group within a foundation or a government agency, that those documents are then picked up and sometimes cut and paste, sometimes used to inform, but they do really wind up impacting downstream where money flows and where some of the activity gets directed. So these documents, even if they're not used or funneled directly into what, for instance, HRSA does with regional support or service centers, many times they are used for future funding opportunities or the direction of future services. So absolutely submit your comments to this. I think that they will be very important going forward because there are not very many documents like this even out there in general.
Right, and building upon that, James, do you anticipate these recommendations being submitted to other national healthcare facilities?
That is a great question. And I absolutely think that we will publish these more broadly, but HRSA, Alicia, I don't know if there's any thoughts from the working group specifically on this topic.
So that is something we have talked about a bit, and we have certainly made a plan to, once we've submitted the recommendation, the final version to HRSA, to turn some of our work toward developing this into a publication. We'd like to see this enter into the literature writ large, if you will. And in terms of submitting it to other healthcare entities, we have not discussed that. But again, if you submit that as a formal comment, that's something that the work group will consider and can add to in the report.
Great. And I can definitely assure you that the data collected as part of these projects, the quantitative data with surveys is something we're absolutely planning to publish, because it's important data that's not out there.
Yes.
Sharon, any other questions?
No, I don't see any other new questions.
Okay, well, and that is almost perfect timing for the end of the webinar. I want to absolutely thank Alicia for joining us today, and all of our attendees. This is an important topic. If you thought it was informative and that that you know individuals who might be interested in participating, please share with them the document or the link that will be published soon to the webinar archive. We want to get as many people informing these recommendations as possible. If you're interested in future webinars, please sign up for our announcements list at Genetic Alliance. We frequently host webinars on different topics in health and genetics, and you might find some of the other archived webinars interesting as well. So with that, I'll say goodbye, and if you have any questions too, please feel free to send them our way. Thank you very much.